Recording in progress.
Praveen sir, you can unmute yourself.
Yeah, thank you. First of all, I would
Yes, sir, you
congratulate the
we can
organizers.
hear you. Put your presentation on. Yes, definitely. You're perfectly going on, sir. You can go.
First of all, I would like to congratulate the organizers of the CME for a wonderful CME which is going on hypertension. I was given the topic of kidneys and hypertension, and I would be very brief. Like maybe I would complete the topic before the time allotted to me. Let's begin. Hypertension is one of the leading cause of global disease and affects more than 1 billion of individuals and around 10 million deaths per year. Hypertension usually doubles the risk of cardiovascular diseases such as coronary artery disease, congestive heart failures, cerebrovascular accidents, peripheral arterial disease, and renal failure. The genetic and environmental factors also contribute to the prevalence of hypertension, out of which obesity, weight gain, high dietary sodium chloride intake, low dietary intakes of calcium and potassium, alcohol consumption, psychosocial stress, and low level of physical activity, that is sedentary lifestyle, is one of the leading causes of the hypertension. Genetic considerations has also been taken into the mind. Its hypertension is considered to be a polygenic in inheritance. There are significant heritable components into the range of 30 to 40%, with more than 25 mutations and more than 100 hypertension related polymorphisms, which are seen in the pathways related to hypertension regulation or blood pressure regulation. Also, there is a phenomena called genetic anticipation in hypertension. Just go through the mechanisms of hypertension. For understanding the regulation of arterial blood pressure, normal or elevated, is necessary to formulate the treatment strategy. The determinants of hypertension are cardiac output and the peripheral vascular resistance. And the cardiac output, as we know, it depends on the stroke volume as well as the heart rate. And the stroke volume is directly proportional to the myocardial contractility and the size of vascular compartment. And the peripheral vascular resistance is proportional to the functional and anatomical changes in the small arteries, arterioles. The intravascular volume, which is related to most of the time kidneys, is both the kidneys is considered as target as well as the cause for hypertension. The mechanism of secondary hypertension is usually most of the time related to kidneys. And the mechanisms are reduced capacity to excrete sodium, excessive renin secretion due to volume status, that is pressure natriuresis, and autonomic nervous system sympathetic overactivity. Sodium chloride, that is salt, can activate various neural, endocrine, and paracrine as well as vascular mechanisms. And that's why the non-chloride salts of sodium has a relatively little effect on the blood pressures. Salt retaining leading to volume retention leads to hypertension. This is a simple phenomena. And conversely, if there is a diseases which are salt losing or salt wasting, then the diseases are associated with the low blood pressure or hypertension, I would say. Autonomic nervous system, that is norepinephrine, epinephrine, dopamine are short-term tonic and phasic cardiovascular regulators. The hormones and volume-related factors associated with the long-term BP regulations. Norepinephrine, epinephrine, and dopamine are mediated through G protein coupled receptors, and there are the adrenergic receptors like alpha 1, alpha 2, beta 1, beta 2, and alpha receptors bind avidly to the norepinephrine, then epinephrine, and the converse is true with the beta receptors. The alpha receptors are postsynaptic vasoconstrictors and increases the tubular reabsorption of sodium. Alpha 2 receptors are presynaptic. It inhibits the secretion of norepinephrine and will eventually decrease the blood pressure. The beta 1 receptors are in myocardium. It stimulates the heart rate, and the strength of the to increase the cardiac output, and it stimulates the renin release from the kidneys. Beta 2 receptors stimulation relaxes the vascular smooth muscles, leading to the vasodilatation. The arterial baroreflex mediated through the stretch sensitive sensory endings in carotid sinus and aortic arch. These baroreflex control of blood pressure usually deteriorates with the advancing age, hypertension, and atherosclerosis. The autonomic neuropathy and impaired baroreceptor function is associated with the labile hypertension or a labile blood pressure. The next mechanism of action is mostly related to kidneys, and this is like the RAS system or renin angiotensin aldosterone system. It controls the blood pressure via vasoconstriction by angiotensin 2 and sodium retention by aldosterone. The stimulus for renin secretion is decreased sodium chloride in macula densa. This leads to decreased pressures of stretch of renal afferent arterioles through the baroreceptor mechanisms, and the sympathetic nervous system activation of renin secreting cells by beta 1 receptors. The angiotensin 1 receptor mediates the activation of angiotensin 2, the potent vasopressor and a trophic substance for secretion for aldosterone. Angiotensin receptor 2 is a vasodilator, sodium excretion, and inhibition of the cell growth and the matrix formation. And aldosterone is the potent mineralocorticoid. Some vascular mechanisms are there, like vascular radius and the compliance of the resistant arterioles. The resistance to the flow is inversely proportional to the fourth power of the radius. Hence, the small decrease in the radius increases the resistance significantly. Also, arterial stiffness is the manifestation of hypertension. Mean arterial pressure is cardiac output multiplied by peripheral resistance. And one more term you need to know is like aortic augmentation index. That is central aortic pressures divided by pulse pressures. The last contributory mechanism for the hypertension would be immune mechanisms from inflammation and oxidative stress. Low-grade inflammation and uncontrolled activation of immune systems associated with vascular injury and hypertension. Both T cells and B cells are considered to be involved in this. Increased in the sympathetic nervous system activation also is possible with chronic inflammations. Mechanical forces in the vascular walls, interstitial sodium concentration, and a high salt intake are considered to be the factors for increasing the blood pressures. So the definition of hypertension as given is like normal is less than systolic blood pressure less than 120 and diastolic less than 80. Normal elevated would be the 120 to 129 of systolic blood pressure and less than 80 of diastolic. Stage 1 hypertension and stage 2 hypertension. Stage 1 is like 130 to 140 systolic blood pressure and the diastolic blood pressure of 80 to 89. And stage 2 hypertension is more than 140 millimeters of mercury systolic and more than 90 millimeters of mercury diastolic blood pressures. But along with these numerics, we need to consider few more things while labeling the patients as a hypertensive. The level of blood pressure at which addition of treatment reduces the blood pressure related morbidity and morbidity. On an average, 2 or more seated BP recordings should be during the two separate OPD visits. In children and adolescents, The systolic blood pressure and diastolic blood pressure should be more than 95th percentile of age, sex, and the height. And the blood pressure between 90 to 95th percentile should be considered as a pre-hypertension. Ambulatory blood pressure monitoring is the best out of office or out of OPD method of BP measurements. Normally, there is a 10 to 20% dip of blood pressure in the night, and the attenuation of this nighttime dip of blood pressure is the earliest indication of hypertension and the coronary artery diseases. We need to consider white coat hypertensions, that is increased office BP but normal home and ambulatory blood pressure monitoring. And masked hypertension also, like we need to consider the normal office BP but raised home as well as ambulatory blood pressure monitoring. So these are the few the kidneys, like as the topic given to me is the kidneys along with the hypertension. The kidneys, there are two ways the kidneys can be considered in hypertension. One is as a cause and the other one would be as a target organ. The cause would be renal parenchymal disorders like acute renal failure, chronic renal failure, acute glomerulonephritis, tubular nephritis, autosomal dominant polycystic kidney disease, and obstructive uropathies. The renal vascular disorders also has to be considered in the mind. That is renal artery stenosis as well as fibromuscular dysplasias. Renal hormonal disorders like erythropoietin and other things are known to increase the blood pressures. Renal metabolic disorders like congenital adrenal hyperplasia, diabetes, hyperaldosteronism, and all of those things. Renal angiotensin aldosterone system plays a central role of salt and water retention or homeostasis and blood pressure control. Juxtaglomerular apparatus, that is granular cells, synthesize and releases the renin, which acts on angiotensinogen to produce angiotensin 1, which is converted by angiotensin converting enzymes in the lungs to angiotensin 2, which acts on 81 and 82 receptors in the kidneys. This renin release is mediated by decreased afferent arterial pressure, sympathetic nervous system activation, decreased sodium delivery to distal convoluted tubule, and through the prostacyclin and ACTH. The causes of renin release increases are renal artery stenosis, renal cell carcinomas, benign reninomas, antihypertensives like calcium channel blockers and diuretics, and in essential hypertension. Actions of angiotensin 2 are like arteriolar vasoconstrictions, efferent renal arteriolar vasoconstriction, aldosterone secretion, adrenaline release, smooth muscle hypertrophy, increased reabsorption of sodium in proximal convoluted tubule, inhibits the renin release, a negative feedback, a renal mesangial cell growth and matrix expansion, myocardial growth, stimulates the thirst and ADH release. The other part of the RAS is aldosterone, which acts on the collecting duct to promote the sodium reabsorption and potassium excretion. Hypertension, low plasma renin activity, cardiovascular diseases, and renal damage. The ratio of plasma aldosterone to plasma renin activity is a very useful screening test. One is associated with adrenal adenoma. Now, in this as hypertension, usually it presents as a benign nephrosis with fibrinal necrosis and flea-bitten kidney appearance. Glomerular sclerosis, like focal segmental glomerulosclerosis and other glomerulosclerosis. Persistent proteinuria, which can be microscopic or macroscopic sometimes. Microscopic hematuria also, and small kidneys. When should we suspect kidney disease in hypertension? When the patient is younger than 30 years, the blood pressure is having sudden onset of over the previous stable blood The
Recording in
requirement of
progress.
the antihypertensives is considered to be more than 4 or 5. Deranged or raised kidney parameters like creatinine, urea, and other. Sorry. Unequal kidneys, like in cases of renal artery stenosis, one can have unequal kidneys. Usually, the flash pulmonary edema is usually present in the kidney-related hypertensions. Persistent proteinurias and microscopic hematuриas has to be considered as a patient having renal hypertension. And abdominal bruit, which is one of the classical findings in the renal artery stenosis. We have to consider few things while considering the hypertension because of the kidneys. Is this a sustained hypertension? Is this a primary or a secondary hypertension? Are there other severe risk factors? And is there a target organ damage? We usually advise following investigations in these patients. One is urine analysis, the kidney function test like creatinine, blood urea nitrogen, EGFR calculation, urine examination, and serum calcium levels. Blood glucose and HbA1c, as diabetes is considered to be one of the cause which can create hypertension through the kidneys. The ECGs, echoes, urine albumin creatinine ratio or protein creatinine ratio, acid, arterials, plasma renin, and aldosterone activities sometimes has to be considered, and sonography abdomen for renal sizes, corticomedullary differentiation, calculus, and renal artery Doppler sometimes. Management of the hypertension which is related to kidneys, there are few common guidelines and but a few are kidney related. One is weight reduction. We should 6 grams
Recording
per
in
day.
progress.
We should adopt a DASH diet, that is dietary of hypertension diet, which is rich in fruits, vegetables, low in fat, and dairy products. Diet rich in potassium, calcium, and magnesium is promoted and will cause the control of the hypertension. The alcohol consumption should be in moderation, but these are Western guidelines. In India, I would consider that there should be no alcohol consumption, but like conventionally, less than 2 drinks for male and less than 1 drink for female is to be strictly followed. And physical activity, the regular aerobic activity such as brisk walking or slow jogging for around 30 minutes has to be followed. The treatment of hypertension, kidney hypertensions, CC and AHA, one is like indication use BP lowering treatments, that is secondary prevention of recurrent coronary CVDs events in patients with CVD with systolic blood pressure of more than 130 and 80. The primary prevention in the patients with estimated 10 years ASCVD risk more than 10% with systolic blood pressure of 130 and diastolic of 80. Primary prevention of
Recording in
confirmed
progress.
hypertension and known case of CVD and known ASCVD risk of more than 10%, the BP target of less than 130 to 80 millimeters of mercury. The possible exceptions are patients with more than 80 years of age, patients previously untreated for hypertension with ischemic stroke or TIA, and acute. The antihypertensive treatment armamentarium is like beta blockers, alpha blockers, vasodilators, calcium, centrally acting antihypertensives, calcium channel blockers, diuretics, ACE inhibitors, ARBs, and renin inhibitors. And the last four are having majority of action through the kidneys. Earlier lecture had covered almost all the new and recent advances in the treatment of
Recording
distal
in
convoluted
progress.
tubules. The problems are hypokalemia, raised sugars, raised triglycerides, uric acid, sometimes erectile dysfunctions, and cannot be used with patients who are on lithium treatment. The loop diuretics, which blocks the sodium potassium 2 chloride channels in thick ascending limb of loop of Henle. Sequential nephro blockade to be considered in the patients who are edematous, like to overcome the diuretic resistance, includes the loop diuretic as well as the thiazide diuretics. Some potassium sparing diuretics are also important, which blocks the epithelial sodium channel in late distal convoluted tubule and collecting duct. Calcium channel blockers, though is majority of action is on the arteriole, but has to be considered in the kidneys. Two kinds of these are there: the dihydropyridine, that is DHP, and non-DHP. The dihydropyridine usually blocks the voltage-dependent type of calcium channel, decreasing the calcium entry into the smooth muscle and decreasing the smooth muscle contraction and leading to the arteriolar vasodilatation. And as we know, the smallest dilatation in the arteriole will reduce the blood pressure significantly. The non-dihydropyridine derivatives are usually cardiac. They are used as an antiarrhythmics. Why we use DHP CCBs? This has got a better BP lowering effect, less BP variability. It can be combined with any antihypertensives. Is a good choice in patients with angina, effective in low renin blood pressures. They are lipid neutral. BP reducing effect not blunted by NSAIDs, but the side effects are flushing, tachycardia, peripheral edema, gum hypertrophy, and not effective as ARBs and ACE inhibitors against hypertension or diabetes related kidney disease, nephroprotective wise or a kidney protective wise. Angiotensin converting enzyme inhibitors like initially captopril, enalapril, and now the ramipril, perindopril, and other things blocks the angiotensin 1 conversion to angiotensin 2, having relatively mild antihypertensive effects, but they are very much cardioprotective and nephroprotective. They have a synergistic effects with diuretics, beta blockers, calcium channel blockers, alpha blockers. The combination with ARB is not recommended as it would lead to complete RAS blockade. It would be decline in the renal artery stenosis, decline of the KFTs in the renal artery stenosis, congestive cardiac failure, and volume depleted status, and will lead to deleterious hypotension, hyperkalemia, cough, and angioneurotic edema sometimes. 82 receptor blocker of 81 leading to inhibition of vasoconstrictive effect of angiotensin 2 has a comparable efficacy with the angiotensin converting enzyme inhibitors and synergistic with diuretics and renal protection is documented. Renin inhibitors antagonizes the RAS system. Aliskiren is not commonly, but used, not very popular, only indicated in high renin blood pressures. No apparent CV or renal benefits. Increases the potassium and decreases the blood pressure. Non-pharmacological treatment for hypertension, there are few. Renal denervation with radiofrequency energy, thought to be associated with reduction blood pressure, usually done endovascularly in the patients with the resistant hypertension by a cardiologist. Blood pressure not the definition of resistant hypertension in this, which is given, is like BP should not control even after the 5 antihypertensives. The mean reduction of blood pressure with this treatment is around 28 to 32 millimeters of mercury. The benefits are sustained for around 3 years. Around 15% treatment failure is there, and the disadvantage is in invasive procedures. Few other non-pharmacological treatment for hypertension is device-guided respiration, which promotes the slow and deep breathing, and the other one is the baroreceptor activation methods. So this is from my side regarding the kidneys and antihypertensives. Thank you, organizers.
Thank you very much, sir. Can you hear me?
Thank you very much, sir.
Okay, thank you very much.
Yes, sir. You can
I would
stop.
like to thank Dr. Shafi Saab. He is my batchmate from IGMC Nagpur, and I congratulate him for organizing this wonderful CM.
Yes, sir. Thank you, sir. Dr. Shafi sir is here, and he would like to present a memento to you.
Thank you, Shafi bhai. Thank you.
Yes, thank you, sir. So next, I would like to call upon our next speaker, Dr. Ehsan sir, a very dynamic consultant diabetologist at Diabetes Center, practicing since last 12 years in city of Aurangabad and the periphery. He is director of Diabetes Care Center and Khushi Women's Hospital in Aurangabad, Maharashtra. He has been a regular and a very beautiful orator in national and regional diabetology conferences. He is the university ranker in diploma in diabetes of Mumbai University. He has presented many posters in conferences, one of which we will like to highlight is the real life experiences using vildagliptin versus sulfonylurea, which he has presented in Lisbon in 2011. He had participated in GARD studies of vildagliptin by Novartis, one of the investigator in landmark trials by Sanofi. He is in organizing committee member of RSSDI 2009, and he is treasurer of DIPSICON 2016 held in Aurangabad. Sir, all over to you. You can share your screen.
Yeah, respected chairs. Thank you, Dr. Zubair, for the kind introduction and kind words. I'm audible?
Yes, sir. Yes, sir. You are audible.
It is proper, no problem?
Yes, sir. Very, very, very proper.
Yes, thank you. So, good afternoon, esteemed delegates. Next 20 to 25 minutes, I will be talking on the hypertension updates in diabetes. Since morning, I have listening lectures with all great details. Actually, I'll try to save some time. My topic is very simple and small, so I will be very specific to my topic. Actually, as the Indian patients and the Asian Indian patients, actually, we are having very high risk of development of metabolic illnesses like type 2 diabetes, hypertension, dyslipidemia, central obesity. The more worrisome part as a Asian Indian patients is actually we are having very high predisposition of the metabolic illnesses due to very high fat content, visceral fat content, the high insulin resistance at lower BMI, so that we develop type 2 diabetes, hypertension 10 years before the Western population. So this is the very much a worrisome fact as far as healthcare professionals are concerned, and this is creating a largest burden on our health system actually. We know that this is the dual combination, like hypertension and diabetes, they go in hand in near about 40 to 80% of the patients. At diagnosis, we have got hypertension in diabetic population near about 50% of the patient. If patients are not having hypertension, in diabetes, the risk of developing hypertension is 2.5 times high. And if patients are having diabetes, development of hypertension in this patient is also twice high. So both share the common pathology. If you see the prevalence of the hypertension in type 1 diabetes, it is near about 25% of the patient. At diagnosis, the prevalence varies from 20 to 40%. With microalbuminuria, it is seen in 30 to 50% of the patients, and with macroalbuminuria, it is seen in 65 to 88% of the patients. In type 2 diabetes, at diagnosis, 50% of patients of type 2 diabetes, they diagnosed hypertension. And along with the microalbuminuria, almost 80% patients have hypertension, and in with macroalbuminuria, more than 90% patients have hypertension actually. So in 50% of the patients, we are having hypertension to treat. And as far as diabetes is concerned, diabetes management is not only restricted to glycemic control actually. It is equally important to control the blood pressure of the patient. It is equally important to control the weight of the patient. It is equally important to control the lipids of the patient and to prevent the complications. If you see the magnitude of the problem in India actually, we are having the burden of 31 crore of the patients having hypertension in our country. And the worrisome fact is that among that 31 crore of the patients, only 50% of the patients are aware that they are having hypertension. And among that 50% of the patients, only 50% patients are taking treatment. And among that 50% patients, those receiving treatment, only 50% patients are under control. So this is the rule of half, which is applicable to Indian habits. So this indicates there is a lot of room for the improvement of the metabolic care in our country. And the same are still undiagnosed in our country. So this is the very important, and this indicates that there is a large room for the improvement of the metabolic care in our country. And we have to do the regular screening, detect maximum number of patients at lower age of onset, do the lifestyle that patient up to the target so that we can prevent the micro and macroscopic complication in the future life. So this is very important. If you see the data or projection of the magnitude metabolic diseases in India, diabetes, pre-diabetes contributing to near about 24 crores of the patient. And if you see the hypertension, 31.5 crore of patients are having diagnosed hypertension. If you see the distribution among the rural and urban areas, it is approximately rural areas are not lagging behind in the metabolic illnesses nowadays, and they are showing equally high figures as compared to the west urban population. So this is the data from the ICMR in-depth study from launched in the Lancet actually. If you see the control status, this is very important slide actually. If you see the control status of the metabolic parameters in our country, diabetes is controlled only in 36% of the patients who are maintaining HbA1c less than 7. Blood pressure is controlled only in 50% of the patient. Cholesterol is controlled in almost 65% of the patient. Triglyceride is controlled in 48% of the patient, and LDL is maintained under target range less than 100 in 42% of the patient. If you combine the A1C, cholesterol and blood pressure, it is controlled only in 8% of the patient in our country. So 90% patients who are having risk of metabolic illnesses in the form of diabetes, blood pressure, dyslipidemia, 90% patients are not maintaining their target, they are not under control. So this definitely increases our responsibility as a healthcare professional. So we have to treat our patients up to target. Definitely we are lagging somewhere line in the system actually. Now coming to the pathology, since morning we are learning this pathology. The hypertension and diabetes, they share the pathology of same pathology like insulin resistance in the background of genetic predisposition and environmental factors. We can see here this insulin resistance and hyperinsulinemia leads to inflammation. It leads to increase in the neurohumoral activation in the form of renin, angiotensin, aldosterone system activation. There is sodium retention and volume expansion. There is sympathetic overactivity, and we have to target all these three parameters as far as neurohumoral activation is concerned. On the other side, we are having oxidative stress with the increased vascular ventricular remodeling, endothelial dysfunction, arterial stiffness, which increases the peripheral resistance and leads to the high hypertension actually. So everything is going on in the background of high genetic predisposition, environmental factors, lack of sleep, different addictions and stress and all that. Now these are the definition and screening of the diagnosis. Since morning we are knowing normal blood pressure is 120/80, pre-hypertension 120 to 139, stage 1 is 140 to 159, and diastolic is 90 to 100, stage 2 is more than 160/100 actually. So these are the definition of screening. Now what is the peculiarity of the hypertension in diabetic patients actually, that we are going to talk. In the pre-hypertensive patients, we have to just do the lifestyle modification. I'm coming to that details like proper diet, proper exercise plan, adequate sleep, lack of addiction, everything we have this come under the lifestyle modification. But stage 1 and stage 2 needs the proper anti-hypertensive treatment. In case of pre-hypertensive stages, along with diabetes or CKD, we have to maintain the lifestyle modification. And if you are not able to sustain the target that is less than 130/80, we have to give the drug treatment actually. So the ADA recommendation that to maintain the target blood pressure in diabetic patients should be less than 130/80, and always measure the orthostatic hypotension at each and every visit for the diabetic patient to rule out the autonomic neuropathy. Now, screening and diagnosis. We have talked since morning. We have talked just to complete the forum. I'll just tell you, whenever patients are coming to you, every visit you have to check the blood pressure. Keep the room calm and quiet. Tell the patient to take rest for 5 minutes. Do check blood pressure readings in the 3 formats, 1 minute apart. Take the average of last 2 readings, and check the postural drop as well. If the patients are in the lying down position, wait for 1 minute and then check blood pressure. If the postural drop is significant, more than fall in the systolic blood pressure more than 20 millimeter of mercury, and more than 10 millimeter of mercury in the diastolic, this is significant postural drop. It indicates autonomic neuropathy actually. So every visit we are supposed to check this. If patients are having masked hypertension, like they are borderline hypertension and they are not having usual readings of high blood pressure, this is called as masked hypertension. In that case, there is a very good tool that is called as the ambulatory blood pressure monitoring system. This is very easy and very handy tool which we have to use. Apply that tool, send the patient at home, check the blood, take the readings for 24 hours, and then we can definitely detect at what time of the day patients are having hypertensive readings actually. This is very good tool to rule out the white coat hypertension. This is very good tool to be helpful in the resistant hypertension, and this is also useful to detect the cases of masked hypertension. So if patient diagnosed hypertension, what is now I am going to talk regarding what is the peculiarity of the hypertension in diabetic patients particularly. So these patients are typically shows the lack of nocturnal dipping in the arterial blood pressure, lack of nocturnal dipping. This Dr. Rizwan sir is going to talk on the hypertension in the cardiovascular illness. Definitely is going to give the significance of lack of nocturnal. Lack of nocturnal dipping is associated with the increased risk of stroke and myocardial infarction. So nighttime blood pressure control is very essential in diabetic patient to reduce the CV risk actually. So this is one peculiarity. Second peculiarity is this hypertension is salt sensitive. So sodium sensitivity is found in the diabetic patient in the absence of nephropathy as well. So if we are controlling the salt intake in this patient, definitely we are giving very good help to control the blood pressure in the population. Third category is like there is a systolic blood pressure rise in majority of the patient at the time of microalbuminuria, which leads to rapid progression to the nephropathy. And isolated systolic hypertension has got a high risk of micro and macrovascular complications. So these are the 4 peculiarities of the hypertension in particularly diabetic population. Now coming to the management straight away, lifestyle modification is very essential and very important part of the management of management of hypertension in the diabetic population. See, proper diet and proper exercise and weight loss implementation program, good adequate sleep of 8 hours, and keep the patient away from the addictions like any form of tobacco, any form of alcohol. All these things we need to stop and regulate actually. So what is the significant weight loss in the metabolic illnesses? If patients are doing 5 to 10% of the weight loss at in the duration of 1 year actually, so this is called as significant the significant weight loss, which gives the good metabolic benefits actually as far as glycemic control is concerned and as far as the reduction in the blood pressure is concerned. So 1 kg reduction will reduce the blood pressure by 5 millimeters of mercury in the hypertensive patient. Diet, which Pant sir has already spoke about, the dietary approach to stop hypertension. It is rich in the fruits and vegetables and whole grains, and reduction in the fat, and the trans fat gives rise to very good blood pressure reduction up to 10 to 11 millimeters of the mercury. Now, third point is in the lifestyle modification is reduce the sodium intake to less than 1.5 gram per day. So this is the sodium content actually, and sir was talking regarding the salt content actually, which we have to reduce to 2.3 grams in a day. So sodium reduction up to 1.5 milligram or 1.5 gram per day will reduce the blood pressure by 5 to 6 millimeter of mercury, and then simultaneously we have to increase the potassium content like up to 3.5 to 5 gram. It is rich in the fresh fruits and nuts actually. Coming to the exercise is very important. All the metabolic illnesses, the ADA guidelines, the AAC guidelines, they recommend to do the aerobic exercise at least 150 minutes or 30 minutes in a day, or maximum 150 minutes per week. But in that exercise also try to achieve the maximum heart rate up to 80%. That gives rise to reduction in the blood pressure by 5 to 8 millimeters of the mercury. Along with that, we have to do some resistance exercises, because nowadays there is a concept called as sarcopenia, which is a very bad state of the muscle in the patients, particularly in the patients with the metabolic illness. Less muscle mass is very dangerous as far as metabolic risk is concerned. So we have to not only control the weight of the patient, but simultaneously it is very essential to increase the muscle mass in the patient. So that to increase the muscle mass, we have to cut down the carbohydrate, we have to increase the protein content in the diet, and do some strenuous exercises like push-ups, pull-ups, weightlifting and all. That exercise for 15 to 20 minutes and 30 minutes of the deep walking in the form of aerobic exercises, which is very essential to control the metabolic risk. And then the control of moderation of the alcohol, already I spoke about. So the general treatment, like the drug of choice, I'm going to talk regarding in detail regarding the guidelines and the resistance hypertension, but the general recommendations in the patients of diabetes, patient has to be on ACE inhibitor or ARBs. Generally, diabetic patient require multiple drugs to control the blood pressure. Aspirin therapy is very essential and is very ethical to give aspirin to all patients with diabetes with hypertension. The patient for the primary prevention essential, unless contraindicated, every patient of diabetes with hypertension, with cardiovascular risk, it has to be on aspirin therapy, number one. Number 2 point is statin therapy is also very essential to control the blood, to control the LDL levels. All the diabetic patients should be on these statins for lifelong treatment, because in spite of lipids level actually, if lipid levels are high, definitely it is indicated, but even though lipids levels are normal, we have to give therapy, because in diabetic patients the quality of lipids is very bad. It is a high dense LDL, which is very highly atherogenic and leads to cardiovascular illnesses. So statin has to be there in the therapy for lifetime. So these are the points I would like to tell you. So what is the need of the control of the blood pressure? Because we know that both the conditions, they are having high risk of premature micro and vascular complication. They increase the mortality and morbidity in the future life. These are the background mechanism of development of complications due to diabetes and hypertension. In the background of insulin resistance, dyslipidemia, genes and obesity leads to diabetes, hypertension, atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling. This causes micro and vascular complication. Now, what is the impact of this double condition in the day-to-day clinical practice? If the patients are having hypertension and diabetes, both all-cause mortality is getting doubled here, all CV events getting doubled here, risk of MI getting double, stroke also getting double. So it is very essential. This is the data from the Framingham cohort. and the end organ damage is also seen high in the population with the diabetics actually. So prevalence of LVH is 72% in the diabetic hypertensive patients as compared to 32% of the patients in the non-diabetics actually. Cerebrovascular accidents are very common. Hypertension, mainly systolic hypertension, is strongly and directly related to stroke in all age groups. Presence of diabetes more than the double double the risk of developing strokes with the hypertension. Lowering blood pressure in the patients with hypertension and diabetes reduce the risk of stroke by 44% of the patients. So, what is the landmark study of the diabetes, like UKPDS study? UKPDS study shows that the 10 millimeter of mercury reduction in the systolic blood pressure reduces the 12% reduction in the all-cause mortality or complication related to diabetes, 15% reduction in the deaths related to diabetes, 11% reduction in the myocardial infarction, 13% reduction in the microvascular complication. Now coming to the guidelines. There is a flood of guidelines given for the treatment of hypertension in diabetes, like EDA guidelines, then guidelines from the European Society of Hypertension, guidelines from the American College of Clinical Endocrinology, the guidelines from the DFROMS textbooks, and the RSSDI guidelines, like the regional guidelines, like the study group of diabetic study group of India. So these are the practical guidelines which I am going to talk. So these are the sites where we have to target so that we can control the blood pressure in the, like, diuretic, which reduces the volume expansion, aldosterone mechanism, aldosterone excess, vasoconstriction and peripheral resistance will be controlled by the calcium channel blockers. Sympathetic overactivation will be controlled by the beta blockers, and RAS inhibitors will help to reduce the RAS activation. So these are the antihypertensive drugs. Since morning we are learning all this medication. Now, what is the drug of choice of as antihypertensive in diabetic population? So definitely AC inhibitors and ARBs on the cards. In type 1 diabetes with micro and macroalbuminuria, AC inhibitors are preferred. In type 2 diabetes with hypertension with no albuminuria, either AC inhibitor or ARB, both are preferred actually. In type 2 diabetes with microalbuminuria, both are preferred. But in type 2 diabetes with microproteinuria, ARB shows to reduce the progression towards the CKD actually. So what are the guidelines to recommend? These are the European study of hypertension guidelines. They also, all the guidelines, they are more or less same. The target blood pressure is less than 130 by 80 in majority of the guidelines actually, and there is only differences in the switching of the antihypertensives. Like for some guidelines says AC inhibitors and ARBs on the top in the list. Then some says either you go for some says go with the calcium channel blocker, some says go with the diuretic, some says we can add with the a combination of triple drug if required, and then we can use the beta blocker. Some points regarding the beta blockers I would like to highlight over here. Many patients who are coming to our OPD day-to-day OPD, they are already on the beta blockers, and beta blockers are supposed to be used in specific set of the patients with the diabetes, particularly those who are having cardiovascular risk, we are having a thyrotoxicosis, those who are having the risk of arrhythmias actually, and that too cardioselective beta blockers in the form of bisoprolol or metoprolol. And if patients are having heart failure, then carvedilol is recommended. The problem with the beta blockers, high doses of beta blocker in diabetic patient gives rise to hyperglycemia, number one. Number two, they gives rise to dyslipidemia. Number two, they gives rise to erectile dysfunction. Number four, they gives rise to hypoglycemic unawareness. So it is very dangerous if patients are having hypoglycemia, but they don't feel the symptoms of hypoglycemia due to the masking effect of the beta blocker. So this is very dangerous condition. So try to avoid beta blockers, and if they are indicated, definitely we have to use them, but the use has to be judicial. So these are the ESC guidelines. These are the ADA guidelines, like we have to initiate the one agent like AC inhibitor or ARBs, go with the if patients are not maintaining target more than 130 by 80, add the calcium channel blocker. If not maintained, then add the diuretic. More or less guidelines are same actually. So these are the American Association of Clinical Endocrinology guidelines. I am going to talk regarding the guidelines of the RSSDI, Research Society of Study of Diabetes in India. They are very practical and they are good, very good guidelines to treat our Indian patients actually. So in the background of proper lifestyle modification, we have to start the one single agent with either ACE inhibitor, if not tolerated ARB. Monitor renal function and potassium. If BP is not controlled, more than, if still BP is more than 130/80, add the diuretic number 2. Number 3, if still blood pressure is not controlled, go with the non-dihydropyridine calcium channel blockers like cilnidipine or amlodipine. And still blood pressure is not controlled, then go with the beta blockers. Yes. Yes. Yeah. So these are the guidelines. So recommended ARBs like telmisartan, azilsartan, cilnidipine, amlodipine, or combination can be used. If the blood pressure is more than 150/90, we can straightway start with the 2-drug combination, monitor blood pressure by every monthly. If not controlled, then add the diuretic to the therapy. Try to treat the patient up to target, do the screening on the regular interval of time, monitor potassium and the renal function at regular interval of time, and do check the end organ damage every yearly actually. If still blood pressure is not controlled, we can add the cardioselective beta blockers to the therapy. If still blood pressure is not controlled in some set of patients, we can definitely go with the alpha blockers as well. So these are the hypertensive guidelines comparison. As I already spoke about, more or less the starting of the blood pressure range more than 140/90 is definitely this is the point where we have to initiate the treatment along with the lifestyle modification, and target blood pressure is 130/80 in majority of the guidelines. Now, just 2 slides for the resistance hypertension. If patients are on 3 drugs, and if the blood pressure is more than 130/80, and among that 3 drugs is one drug is diuretic, this is the time we have to label patient as a resistant hypertension. Patient on 3 drugs, uncontrolled, 1 drug is diuretic, still blood pressure is more than 130/80, we have to label this patient as a diuretic. Remember that if you are using thiazide, we have to give the time to the thiazide diuretic to give the good antihypertensive effect, and that will come at the time of 2 to 3 weeks actually. So diuretic will take little longer time to get the desirable antihypertensive effect actually. So what are the causes of resistant hypertension? Many times due to stress, fear, hypertension, hyperventilation. These are the neuronal activity. There are some states of hypervolemia in that particular set of the patient due to excessive use of sodium intake, heart failure, kidney diseases, ineffective diuretic uses, and drug that causes fluid retention. There are some associated conditions in some patients like obesity, older age group patient, endocrine disorders, alcohol abuse, and sleep apnea, and some drug. This is very important. So detailed history is very important in resistant hypertension. NSAIDs are used right, left, in center in our day-to-day clinical practice. Steroids are also commonly used like erythropoietin, lorcaserin, cyclosporin. OC pills are commonly used. Antidepressants are commonly used. So this drug history is very important in case of the resistant hypertension. So there is one terminology called as the pseudo-resistant hypertension, in which we are not titrated dose properly. There is poor adherence to the therapy, and white coat hypertension. These are the category which comes under the pseudo-resistant hypertension. If you cover that, then the patient will be controlled. And if these conditions are not there, in that case, we have to label the patient as a resistant hypertension and modify treatment up to the mark actually. So the incidence of resistant hypertension in India varies from the 5 to 10%, and somewhere in India, like it is near about 20% of the patient. We have to take the detailed history of that particular patient, do some proper investigation in that particular set of the patient, try to increase the dose of the medication. Now newer medications like mineralocorticoid receptor antagonist, eplerenone, and the direct renin inhibitors, all these can be used to treat the patient, but 90% of the patients will be controlled on triple drug with proper dose titration in the background of proper lifestyle modification and reduction in the addictions actually. So this is all about the hypertension in the diabetic population. So it is very just the take home message for the today's talk. 50% patients are undiagnosed. So do screen the patient for diabetes and blood pressure at your regular visits, even though they are not having any risk of metabolic illnesses. Number one. Number 2 point, the proper lifestyle modification with proper diet, proper exercise implementation program, good adequacy of the sleep, and lack of the reduce the addictions is definitely going to help the metabolic condition in our country. There are important devices like ambulatory blood pressure monitoring, which are helpful for our patients to which are recommended to analyze the risk actually. And it is very essential to treat the patient up to target level of less than 130 by 80 millimeter of mercury with proper antihypertensive uses to reduce the cardiovascular risk and end organ damage in our diabetic population. So learn regarding the updated guidelines, do the proper counseling of our patients, sit across the table and give good advice to the patients, use the antihypertensives judiciously, and try to help our patient to treat up to the target level of blood pressure less than 130 by 90. Thank you very much for the patient hearing.
Thank you very much, sir. The presentation was full of expertise on the subject you are dealing with. Sir, I would like to request you to kindly stop sharing your screen.
Thank you, Zubair, and thank you, Shafi sir, for the opportunity.
Sir, Shafi sir is here, and as you are a distant speaker, we would like to present a memento to you, and this memento will reach you soon.
Thank you, sir. Thank you very much.
Thank you.
Thank you.
So our next speaker, very young and dynamic, Dr. Rizwan Deshmukh. He is a MBBS graduate from MGM Medical College, Aurangabad. Did his DNB in internal medicine from SIMS, Hyderabad. Did his DNB in cardiology from Satya Sai Institute of Higher Medical Sciences, Bangalore. His work experience goes in a very huge way. He was consultant interventional cardiologist at Satya Sai Hospital, Bangalore. He was consultant interventional cardiologist at Seth Nandlal Dhut Hospital in Aurangabad. And currently, he is the apex, the atlas of the cardiology department of Apple Hospital, multi-specialty hospital that is situated in Aurangabad. Rizwan sir, you can share your screen and I am giving the controls all to you.
Start now?
Yes, sir, you are audible.
Yeah. Thank you, Zubair.
Yes,
Just
sir,
a
you
minute.
can
Let me
share
just
the
put on my
screen.
slide.
Yeah.
Yeah. Let me just share my slides with you. Right. Are the slides available to you guys?
Not yet, sir. You can share the screen, sir.
Just a minute, huh? Just a minute. Just give me a minute. Just a minute. I'm sharing the screen, right?
Right.
Okay, here's the screen. Fine. Start recording, casting, Zoom. Cancel. Just a minute. I am a bit new at this, so it'll just take me
don't
2
worry,
minutes.
sir.
Fine.
Sir, in our functioning bar, we see mute, stop video, security, participant, and beside this, there is share screen option.
Yeah. Just a minute. Just a minute. See, there's a share screen option. When I'm pressing the share screen option, I am getting documents, screen, camera, and
right.
share.
So open your PPT and minimize it first. First, go to your PPT and minimize it.
I'm going to the PPT.
Yeah.
Yes, the PPT is there.
Minimize the PPT.
Minimize the PPT. Just a minute. Just
right.
a minute. Okay, it's not getting minimized. Just a minute. Wait. Just a minute. Just a minute. Where do you think it is?
Sir, you can minimize this meeting and then normally go to your desktop, open your PowerPoint presentation, and then minimize the PowerPoint presentation so that it will come in the bar below.
Just a minute, sir. Okay, my PowerPoint. Where did you keep my PowerPoint? Okay. Is the PowerPoint presentation available now?
Yes, sir. You can minimize the presentation.
Just a minute. Just a minute. Just a minute. Wait. The thing is that just a minute. Screen. Sitting there, starting a class in Zoom. Presentation.
Recording in progress.
Because I thought I'd be able to do it here. That's unfortunately I'm not able to get it. Okay, I forget. एक minute, just a minute. Can you see it now? Hello? Can you see it now?
No, sir, can't.
Fine. Madam, why don't you do one thing? Why don't you put on my presentation and I'll just tell you when to change and from where to change, all right?
Can see now.
You can see it now? Hello?